diabetes educator and also has personal experience with type 1 diabetes. She works in the emergency room now because she was traveling and that was very hard. So she did leave us a little while ago because she lives in Murrieta, and you can imagine what kind of commute that was like. So we tried varying the hours of the day that she worked, but it was still difficult. So she is now in at a community hospital. So Kelly has extensive experience with diabetes technology and also works as a certified insulin pump trainer for 2 prevalent insulin pump manufacturers, providing trainings to patients across Southern California. Kelly's experience also includes working alongside patients, nurses, and providers in diabetes care, both inside and outside of the hospital setting. In 2015, Kelly started an outpatient diabetes education program at the hospital where she presently works, and she is currently focused on designing an inpatient program. Kelly is also partnering with Riverside County EMS to improve the care of patients with diabetes by providing diabetes-related CEUs to the paramedics and firefighters. Kelly has participated as a patient and a panel member with a well-known San Diego-based diabetes conference. I think it's called Taking Care of Your Diabetes, and she was a participant with Steve Edelman. She's an advocate for persons with diabetes. Her passion stems primarily from her own experience living with type 1 diabetes for almost 20 years. Her primary interests include empowering patients to take charge of their disease and helping them to understand it and bringing understanding to clinicians about what life is like as a type 1 diabetic. Kelly's interests include fitness, reading, fine wine, I'm with you there, and laughter. She spends the majority of her free time camping with her husband and her 3 beloved dogs. So it is my great pleasure, it would be my great pleasure, to introduce to you Kelly. Here she comes. It's okay, we're all looking at you, don't feel bad.
Oh, I don't feel pressure. Okay, hi. I was going to tell you guys a little about me, but I think Jackie did a great job. So I'm Kelly. I work as an ER nurse now. I work as an insulin pump trainer, and I left Sharp a couple months ago. It's a hard decision, but yes, it's a very long commute. So I'm super grateful that Jackie and Ronna had me here today to talk with you guys. My presentation, I'm going to talk primarily about insulin pumps, glucose monitors, and then I'm going to talk a little bit about living with diabetes and thank you. And I'm going to talk a little bit about living with diabetes and some considerations for you guys. I tried to design this to give you guys insight about how you can speak with your patients at the bedside, because most of you guys, I believe, are working in the hospital or outpatient doing diabetes education and things like that. So here are our goals. Like I said, I kind of already reviewed these. And we'll talk about the insulin pumps and the glucose monitors, if they have any, what their role in the hospital setting is, and what your guys' role with those devices are. So basic concepts of an insulin pump for those of you that don't have experience with them. So it's a subcutaneously inserted device. Typically we use one type of insulin in an insulin pump, which is a rapid-acting insulin. We achieve basal delivery of insulin through an hourly basal rate. The basal delivery on an hourly basis will eliminate, in most cases, the need for a long-acting insulin. And then you have bolus delivery of insulin by the patient or the user interacting with the device, telling it how many carbohydrates they're eating, what their glucose is, and then the device is going to calculate a quote-unquote bolus recommendation, which usually the user of the pump will agree to. It's changed about every 3 days, depending on the patient, depending on the type of pump, and how much insulin is actually held in the pump. You may need to change the insulin pump sooner than every 3 days. So I'm sure you guys have seen this before, but I love this picture. It shows, this is the first insulin pump, which is just huge. And when I look at it, it reminds me of when I got married a couple years ago. One of the things I thought about was, well, where am I going to put my insulin pump in my wedding dress? And I was thinking, God, can you imagine? Like, so this is a pretty far cry from what we have nowadays. It's so discreet. I have a pump on now. No one would probably know that. So to me, it's just a huge appreciation of how far we have come. One of the cool things that I read about the first insulin pump, which was designed in the 1960s, was that it actually had a closed-loop system, which is something that we're working on presently. The reason the closed-loop system didn't work, there were so many problems with it, but I was really fascinated to learn that. So again, we've come very far. And most of the devices, some of the devices don't attach to the patient's body, some of them do. So we have tube systems, we have non-tube systems. For the most part, it's going to be a device that looks like this that is in charge of actually delivering the insulin. Some of them are touchscreen, some of them are not as user-friendly in that sense, in that some of them are not touchscreen. Some of our insulin pumps do interface with glucose monitors, and we'll talk a little bit about that as well. So areas on the body that you might find, and I pictured them, is this going in and out?
Yeah. When you turn.
I need to move it?
Face that.
Just stay this
Yeah.
way. Okay. So I put some pictures here to show you guys kind of the size of what these things are. So on the one on the top, it's roughly equivalent to the size of a matchbox. On the one on the bottom, it's equivalent, the site on the skin is kind of equivalent to like a quarter or a $50. So these things are really easy to be missed. And when I was in the hospital doing bedside education, I would talk to the nurses a lot about that. It really emphasizes the importance in the inpatient setting of a full skin assessment, just because they are so easy to miss. And sometimes, like I mentioned, they're not even connected by a tube. So again, it could look virtually normal. You know, you may miss it. It's so easy to miss. And some patients wear these in really unconventional sites. I've seen people wear them like on their thigh, like on their scapula area, which I think would just hurt, but I have seen it done. And those are like more off-label sites, but it doesn't mean that they don't work just as fine. So benefits of pump therapy. There's a lot of benefits, but there's also some disadvantages, which I will discuss as well. For the most part, though, one of the huge things is the reduction in the number of injections that the user needs to do on a daily basis. In most cases, you go from using one type of insulin to two, and the reason I say most cases is because there are still plenty of patients that are on other medications, potentially even still long-acting insulin. I've seen some patients on these devices but still taking Lantus or something like that. But for the most part, we do go from using a basal bolus type therapy to just one type of insulin in the pump. One of my personal favorites of the benefits of pump therapy is how your consistent insulin doses. So, you know, Lantus is becoming a thing of the past in that we have a lot, I would say, we have other long-acting insulins that are lasting longer than that 18 to 24 hour time range. And for me, myself, when I would use Lantus, it never would last 24 hours. So as you get towards the end of that 24-hour period, you're really actually having higher blood sugars because it's out of your system by that point. So with the basal rate on the insulin pump, you're getting that exact same dose all 24 hours of the day. You're getting more precise calculations. So really when you're doing injections, not on an insulin pump, you can get about as precise as about half of a unit when you're injecting from a syringe, sometimes from a pen. There are a few pens that do half units, but with an insulin pump, you can go down to like 0.005 of a unit, which is really beneficial, especially for pediatric patients where maybe their total daily dose of insulin is 5 to 10 units. So those precise calculations are even more valuable. Insulin pumps have features like extended boluses, temporary basal rates. I'm not going to get into those too much, but they, again, allow for more precise doses and for better management of blood sugars based on activity level, based on food intake, things like that. So I have a lot of friends that have type 1 diabetes colleagues as well, and I interviewed some of them when I was doing this presentation because I just think it's helpful for you guys to see and understand what people actually feel about their device, what it actually means to them. So throughout the presentation, I've thrown a couple of those in here. So misconceptions about insulin pump therapy. It drives me crazy when people say that it's easier. It is not easier. It requires interaction from the user. So I would say the results that you get from using an insulin pump are equivalent to what you put into it. If you don't put effort into it, you are not going to have better managed blood sugars. And I would also say insulin pump companies and insurance is funny because you can't have too good of control of your diabetes, but you can't have really bad control of your diabetes because they want to prove it otherwise. So I say that because someone that is horribly managed may not necessarily be a good candidate for insulin pump therapy. They may be, but it depends on why are they not well managed. So it's more of an interview process. We don't look at a patient that has an A1C in the hospital and say, you need an insulin pump, because chances are their A1C is that high because they're probably have a lot of other factors that are coming into play. Insulin pumps do not solve the diabetes problems, I promise you. The other thing is that everyone should be on an insulin pump. That's not true. So I've been doing insulin pump trainings for a couple years, and I have run into, I would say, 2 situations where they were elderly people, and we had already sold them the product, but we couldn't start them on it because they just cannot figure out this technology. So age is a huge factor. It's a really huge factor, and it could be a huge safety concern as well. Type 1 versus type 2, insurance is a beast no matter what. However, people that have type 1 diabetes generally have an easier time. I don't see a ton of patients that have type 2 on insulin pumps, but I would also say that I think that's increasing as well, and I think that insulin pumps are great for people with type 2 diabetes that are insulin dependent as well. When I was in the hospital at Sharp, I remember there's a lot of people that think that insulin pumps are surgically implanted. They are not. They are changed by the user every 3 days. They're stuck to the skin with a strong adhesive, and then there's a small cannula that's underneath the skin. So they're very easily removed and very easily put on as well. So basic concepts of pump therapy. I kind of already went over the basal rate. So the basal rate is what are you getting every hour, and assuming it's a long-acting insulin in the pump. So let's say you have a basal rate of 1.15 units an hour. Your total basal daily dose would be 27.6 units. And if we were to transition a patient from a pump back to injections, we would use that 27.6 as a roundabout for where their long-acting insulin dose should be. Insulin to carbohydrate ratio. So not everyone uses this in the insulin pump. I mean, I would personally recommend it, especially for people that have type 1 diabetes and know how to carb count. So we set insulin to carb ratios in the insulin pump, and it's basically how many grams of carbohydrate does 1 unit of insulin cover. And the last one I wanted to show you guys was the correction factor. So the correction factor is written as a ratio, but how many points in blood sugar reduction do we expect 1 unit of insulin to do? So a correction factor of 1 to 50, we would expect 1 unit of that humalog to lower the blood sugar by about 50 points. So some considerations for you guys at the bedside and working with these patients. So we already talked about anyone could be wearing an insulin pump, not just because they have type 1 diabetes. Some hospitals have policies for inpatient use. I know Sharp does. The hospital that I work at in Marietta, we do not have a policy, which is super scary. I don't even want to tell you guys those stories. So first Sharp, you guys do have a policy. So I think a lot of you are probably pretty familiar with the policy. I won't go over it too much here. However, there are some contraindications. The patient needs to be able to manage the device on their own. If the patient is in DKA, that's an absolute no. We typically don't allow the insulin pumps or glucose monitors in the ICU setting. And then, as I mentioned, during certain procedures, we don't want them going through any sort of X-ray, CT, MRIs. We don't want them in the OR. So there's a whole policy dedicated to this that your inpatient educators will typically go over with you guys. Keep in mind one thing, most infusion sets for insulin pumps are just the plastic catheter. However, there are a few that have the needles that stays inside of the patient. And this is important because when we send a patient to, let's say, MRI, and they have a tube system, we can have them easily unhook from their body. However, if they have the device with the needle insertion that stays in, that would be a consideration. We need to make sure that is removed entirely as well. Okay, CGMs. You guys are probably starting to see a lot more of these. It's a way that we track blood sugar 24/7. There is a small cannula as well as a metal filament that is inserted into the interstitial fluid. And that's an important piece. It's not in the blood, it's in the interstitial fluid. So the blood glucose readings, or the glucose readings we get from the interstitial fluid are not exact as what we would get from the blood, and they're always about 5 minutes behind. They read about depending on the device, every 5 minutes or so. And so keep that in mind. Their blood sugar reading is about 5 minutes behind. You don't even know anymore if someone has a glucose monitor on, because most of the time we can get it on our phone. So there is still always the option for the patient to have the receiver from the manufacturer. However, that is, I would say, becoming a thing of the past. And there's an app for most CGMs, not all, that you can download on your phone, and the patient will either automatically have their glucose reading on their phone, or they'll scan something on their body that will give them their glucose reading. Also not surgically they're also not surgically implanted, and they are also inserted by the user, depending on the model, every 6 to 14 days. Some are more temperamental than others, so sometimes they don't last that full time period. And then the other thing I wanted to talk about in the next few screens is the primary helpfulness of CGM is that they provide information on the rate of change by directional arrows. I'm going to talk about those directional arrows and what they mean and what a patient or person can expect after we quickly talk about this. As I mentioned, it's ongoing. It does eliminate the process of finger sticks for the most part. My personal experience is that you should always calibrate. That is just my personal experience. There are devices that say calibration is not required. I find that the more I calibrate, the more accurate my glucose level is from my CGM, but again, not mandatory for all devices. What's so helpful about these arrows is that it increases the predictability of how high or low your blood sugar is going to go. So when you think about how we traditionally check blood sugar, we poke our finger and we have a machine read it, and it gives us a number, which is helpful, and that's how we've always done it. But what we don't know about that number is which direction is our blood sugar going. Because I will tell you, if my blood sugar is 200 and dropping, I may wait on giving insulin. However, if my blood sugar is 200 and rising, I'm not going to wait, and I'm going to give insulin. Just a couple pictures of what these look like on the body and some of the receivers. So let's talk about the arrows. So the directional arrows, double arrows straight up or down. I can't even tell you how emotional it makes me when I see this on my phone. Those arrows are horrible, they're so scary. However, if you see the double arrows, you know you're gonna be upwards of a 90-point change within 30 minutes, which is super scary, but that's why CGM is so great, because this is information we didn't used to have. So you can get on top of your highs and you can get on top of your lows. So one arrow, either straight up or straight down, indicates a likely increase or decrease of 60 to 90 points within the next 30 minutes. Mm-hmm. When you have an arrow straight across, it does not indicate that your blood sugar is not changing. It indicates your blood sugar is not changing rapidly, and it's changing by less than 1 point a minute. So it's a stable blood sugar to make a dosing decision off of. If you have a diagonal arrow, you can expect a 30 to 60 point increase or decrease in 30 minutes or less. If you have no directional arrow, you cannot or you should not make a treatment decision based on that reading. So like I keep using the word treatment decision, and what I mean by that is most of our CGMs are approved for treatment decisions, which means that we can base insulin doses off of them. We don't have to validate them with a finger stick unless we feel that we should do a finger stick. What's really important is that even if you're using a device that is indicated for treatment decisions, if you don't agree with the number you see, do a finger stick. I had a perfect example this morning after I got home on my run. It said my blood sugar was 210, and I had my pump and I had 4 units dialed up, and I was about to give myself 4 units because I was gonna eat. And I said to my husband, I just don't feel like I'm 210, and I checked my finger and I was 140. So I would have completely bottomed out with those 4 units. So I always tell patients, and you should encourage your patients that you work with as well, that if you don't agree with the number, if it says you have a normal blood sugar but you feel low, check your finger stick and make sure that you're not actually low. If there is no arrow, we don't recommend you make any decision, any insulin-based decision off of this number. Wait until it reads again, until you have an arrow knowing which direction your blood sugar is going. So I think we'll just play the first video. I just wanted to give you guys an idea of how these things are inserted, because I think you guys as clinicians, if you can see how these devices are inserted, I feel like it'll probably make you a lot less curious or nervous, or it may increase hopefully your level of understanding of these things.
Let it dry. Choose a site at least 3 inches away from your insulin draw infusion set or injection. Choose a site at least avoid inches areas like ribs and infusion set and areas with scarring, tattoos, hair, or irritation. Also, you don't want to use the same sensor site 2 times in a row. Remove both labels. Do not touch the adhesive. Place the applicator on your skin. Fold and break off the safety guard. Press the button to insert the sensor. Remove the applicator. You've successfully inserted your sensor. Now it's time to attach your transmitter.
We can stop
Clean
now.
your transmitter.
Thank you. I'm not going to show you guys the other one just for the sake of time. It's just a slightly different device, but showing the insertion process for that as well. So you can insert your sensor for your CGM. Depending on the device in the abdomen or on the arm, there's a lot of other places that patients use for their sensors, just like the insulin pumps, which are fine as well. So considerations for you guys for CGM. These devices, although they may be allowed for use in the hospital for the patient to wear them, they're not necessarily, or they are not approved for nurses or anyone to make treatment decisions. So the benefit of having a CGM on in the hospital would be solely for the patient. Nurses are still required to perform a finger stick on the Accu-Check, the approved hospital device. These are not hospital devices. Hopefully that is a thing that we see in the near future, but we're not there yet. So if your patient is wearing this while in the hospital, there's of course an order set that goes with it, just like with the insulin pump, but it's solely for the patient's comfortability, and the patient is expected to communicate with you if they see a rapid change in their blood sugar, which you can then validate by performing a finger stick. So again, just like the insulin pump, we don't want these devices in certain areas of the hospital, and there is a metal filament that is underneath, that is in the subcutaneous tissue, so please take that into consideration. Okay, so I wanted to talk to you guys a little bit about just living with diabetes, what it's like, how we kind of, when I say we, I mean people with diabetes, things that go through our head throughout the day, and what I wanted to circle back and bring back to you guys is, as clinicians, words that you can use that are helpful for interacting with patients. Okay, so we'll start with this. So my insulin pump is my most beloved device. I know we all don't leave home without our phones, and I don't either. However, even more valuable than my phone is my insulin pump. It is literally my lifeline. So keep that in mind when working with patients. This is not just an insulin pump. It's not, am I the only unlucky one? It is not just an insulin pump. It is literally our lifeline. So please treat it that way. Please ask for permission to touch it. Please don't start pushing buttons. And when you're considering and having discussions whether or not your patient should stay on or off their insulin pump, please take into consideration what it means. And when you do take your patient off of their insulin pump, some of them could not care less. However, if I was your patient, I would want to be part of the process. So please keep that in mind. And again, another couple, some feedback I got. So I'm beyond grateful for my pump. I haven't been diagnosed for long, but since I made the change, being able to take care of myself and my sugars has become easier. My CGM is my lifeline. It's what keeps me sane. If my CGM stops, I feel lost. Whether it's my insulin pump, my CGM, my syringes, my vial of insulin, it is all so personal. It is my lifeline. I know where each of these items are at 24/7, and leaving home without them is the equivalent of leaving home without shoes on. You know something is missing. I want to discuss our relationship with food. So I always tell people I don't look at a plate of food and think that it's just food. Food is numbers, especially to people with diabetes. So when we get a plate of food sat in front of us, we don't sit there and admire how beautiful and delicious it looks. We sit there and we start adding things up. And if you have ever had a meal with me, you will see me. Sometimes I'll just kind of stare at my food for maybe 10 to 30 seconds because I'm counting. I'm literally counting and figuring out what am I going to tell my insulin pump. There are lots of foods that look and sound delicious, but that when I look at them, I know exactly how bad my blood sugar is going to be in a few hours, and I know how angry I'm going to be when it's that high. And I am so careful about this that even if my husband sees me looking at these foods, he probably gets nervous because he knows how angry and mean I get when my blood sugar is that high. So we have such a unique relationship with food. I am in no way saying that people that have diabetes don't eat some of these foods. No, I don't know how to hold that. And unless is it really bad?
No.
Okay. I'm in no way saying that we don't eat foods like this, but what I am saying is we look at food, we make a decision on whether or not we want it, and if we can deal with the consequences. The consequences are not always this bad, but they oftentimes are. On the flip side, I still like to tell people I personally choose to avoid these types of foods simply because I know how it's going to make me feel. I know how badly high blood sugar makes me feel. And then I tell people I love the way that I eat. There are plenty of healthy ways to eat. And this is information that I use when I work with patients, that the diabetes diet, which we will talk about, is not boring, it's not bland, it can be really great. And for me personally, knowing that I'm eating something that's gonna make my blood sugar okay afterwards, that makes me enjoy things even more. So let's talk a little bit about how bad are lows and how bad are highs. So I actually kind of want to start with this slide. So people that have high blood sugar, it kind of depends on where you sit on a normal basis. So if you normally sit in a decent range, maybe 120 to 180 or less, when you have blood sugar numbers like these, you really feel horrible. And those are the people typically that have more symptoms of high blood sugar. People that live at these numbers all the time, perhaps you're a patient that has not been diagnosed with diabetes, or perhaps you're a patient that knows that they have diabetes and maybe doesn't pay as much mind to it as they should. They sit and live at these numbers, so they don't actually realize how badly these high blood sugars are making them feel until they start treating it, their blood sugars get better, and then they realize how horrible they felt. So The physical effects, I would say for me and for someone who doesn't sit at a high average, are, I would say, pretty detrimental. It really can be defeating because you can go from feeling good and energized, and when your blood sugar spikes, it is literally like you just hit a wall. Like you just ran a marathon and haven't slept for days. It can be so taxing. Low blood sugar can be very similar as far as how taxing it can be. So I have a friend that I work with in the ER. She has had type 1 for 26 years, and I hate to say this, but she's low a lot and she's high a lot, and she can kind of snap in and out of them and just get back to working and be totally energetic. And she makes fun of me because when I get a low, I literally just, I feel like I melt. I just feel horrible. Everything stops. I can't take care of my patients. Everyone knows that Kelly's blood sugar is low. Like, I just feel horrible. I literally feel like I was hit by a bus. And then the bummer about low blood sugar that I would say, personally speaking, is not only the dangerous effects of low blood sugar, but having a low blood sugar like this at the beginning of the day makes it so hard to get through the day because it just took everything in you physically to get back to that normal place, and when you're back there, you just don't feel like yourself. So I would say the hardest thing for me is having a really bad low and then having to go to work and perform or do something where I have expectations to fulfill. And again, symptomatic versus non-symptomatic, that's another huge benefit of CGM because some patients have hypoglycemia unawareness. So they may have these super low numbers but have absolutely no idea that their blood sugar is low. And that's why CGM is helpful because they can set their limits to alarm them that their blood sugar is going low. And then I wanted just to briefly discuss rapid changes in blood sugar. So you guys know when you're treating patients, whether it's sub-Q insulin, IV insulin, there is such thing as an unsafe drop in blood sugar. So we try not to change a blood sugar more than maybe 75 points in an hour or so. Even that, in my opinion, personally, is a lot. Anything more than that is actually dangerous for a lot of reasons. The physical, and again, I go back to the physical and mental effects of it, is really, really taxing as well. So these are actually two situations where there, just in an hour and a half, there was a greater than 250 point increase in, well, what can cause this? Well, tons of things can cause this. Obviously, food. A lot of times, I used to get in trouble when I would use a temporary basal rate. If I was going low, I would turn my basal rate down, correct my low, be fine, and then I would skyrocket because I would get that rebound hyperglycemia, but also having suspended or lowered my basal rate for too long, I end up here, and again, you feel horrible again, so you go from 50 to 330. So this is a diabetes home run. There is nothing that makes someone with diabetes feel better than having a trend like this. I will tell you, I screenshot them all the time and use them for positive reinforcement for myself, but really the mental benefits of having good blood sugars, you are aware, you are present, you're energized, and without those drastic shifts, you just feel so much better. And again, these are things to keep in mind for when you're working with your patients. Don't try to talk to your patients when their blood sugar is 50. Don't try to do anything when your patient's 50 besides feed them. When their blood sugar is high, someone comes in DKA, that is not the time for education. When they are in that acute crisis, that is absolutely not the time to sit down and say, let's talk about your diabetes. Let's talk about why your insulin pump stopped working. That's not the time. Wait till their blood sugar is normalized and they can stay awake long enough to have a conversation with you. I just love this. It's so immature, but I am sorry. This is so great. It's true. It's 24/7. It's a full-time job. We are always on shift. Okay, so clinician considerations. I already kind of spoke about this, so just please be mindful of these devices and understanding how meaningful they are to your patients. I want to talk to you guys about the diabetes diet, and I put that in quotes for a reason. But one thing that I've encountered a lot in my career is that there's a lot of misunderstanding about what foods are bad or good. It's not just sugar, it's actually carbohydrates. Carbohydrates are what make or what affect your blood sugar. Sugar is counted within carbohydrates. And I tell this to people because I realize that not a lot of people have an understanding of the nutrition label and really understand what that means. So when I'm looking at a food, I'm going to look at the total carbohydrates. Of course I'm going to look at the fiber and the sugar content, because even with an increased sugar content, I know the more sugar, probably the more rapidly and drastically my blood sugar is going to be affected. But again, I am still looking at total carbohydrates. Sugar alcohols, they can be really, I know you guys had a talk on diet earlier, and I'm not really here to talk about diet, just a couple things. The sugar alcohols, they still have an effect on blood sugar. That's been my personal experience. In some cases, we're taught to teach patients to subtract sugar alcohols from their total carbohydrate content. I find that that's actually very dangerous. They have an impact. My personal just preference, and this is again preference, not a rule, is that I avoid things that have sugar alcohols. I don't mind having real sugar. It actually allows me to better dose my insulin if I have real sugar than when I have sugar alcohols. So I don't personally, and this is a strong word, I don't want to use the word believe, but I don't subscribe to the idea that there is a diabetes diet, because really it's just about eating well, and really it's a good diet for all of us. The diabetes diet is about having balance, portion control. You're allowed to have anything you want if you have it in a safe and reasonable portion. Now, it's more person preference than anything, because this is what I will say. I have some friends that will absolutely eat those foods that I just won't, and that is not wrong on them. That is their personal decision. I know how certain things affect me, and I choose to avoid a lot of things. And then I have friends that have diabetes, and I see patients that are like, you know what, I'm gonna have that, and I'm gonna have it every day as a snack. Whatever it may be, it's person preference. It's not that you're allowed or not allowed to have something. So this next portion of my presentation, I want to talk to you guys about language. This video is about 5 minutes, and that's kind of long, but there isn't much that I have to give to you guys after that. But if you don't mind just watching this, and then we'll talk about it after.
The words we speak and write in healthcare can encourage and inspire. Words can also be hurtful and can blame, shame, and judge. As a community, what we say and how we say it shape our relationships. Choosing respectful, strength-based, empowering language has the power to connect us in conversation and unite us together to improve health. Let's talk about why language matters. As you think about language and word choice, what do you consider to be important?
We need to change our mindset to putting the person first, not our agenda or what we want, but what the person needs. When we approach people with diabetes this way, the appropriate words fall into place because it no longer makes sense to use words like compliance, adherence, or control.
Addressing patients from a cultural lens ensures that we understand their health beliefs, the practices, and how they understand and act on their condition. Language goes beyond translation. It also needs to be mindful of the nuances of each culture.
We need to think about the way we talk about diabetes from the very beginning of care, when a person is first diagnosed. Talk to people with empathy for what a difficult job diabetes can be day in and day out. Let people know that you understand that there is an emotional impact.
From your experience as a diabetes educator, can you share some examples of phrases that use empowering person-first language?
Words and phrases that put the person first include person with diabetes or person living with diabetes instead of diabetic.
must put healthcare practices or goals they would like to work toward. This is person-centered. The person who has diabetes takes the lead.
Let's work together to make a treatment plan that you feel confident that you can do in your everyday life.
You've been doing a great job choosing fewer carbs. What do you want to focus on now? I'm on your side. I'm your partner and your biggest cheerleader to help you reach your goals.
Ask them what's working and what's not working. Give them credit for what they have accomplished. Maybe they're eating vegetables for the first time. Or maybe they're using a medication reminder app that's helping them.
Just simply saying, I appreciate you being here today can really matter.
Rather than labeling someone and assuming they're suffering with diabetes, we can say live with diabetes. We can remind them that we're their partner in finding ways to delay or reduce the risk of complications.
Discuss the benefits of the recommendations that you make. Some people don't even know why they're bothering or why it even matters. And after imparting knowledge, make sure that you ask them, so what do you think of that? How does that matter in your life with diabetes?
As a person living with diabetes, how would you feel if people used words that were person-centered, respectful, and fostered collaboration?
One of the best things a healthcare provider said to me was, let's figure out how diabetes works in your lifestyle. To me, that meant she respected that my life does not revolve around diabetes, and that together we could find ways to set realistic goals for my diabetes management. Ultimately, this affects me in a positive way, physically, mentally, and emotionally.
I would feel like they saw me as a person living with diabetes instead as a patient with diabetes.
I would feel respect, like I am part of a team that's helping me live that life.
I would feel like they understand that I'm the expert about my daily life with diabetes. I would feel respected and that my input matters. Language matters.
Language matters.
Language matters.
Language matters.
Language matters.
We can all make a difference through the words we choose. Join us in this empowering language movement, because language matters.
What did you guys think of that?
Great.
So the AADE and ADA, this is a really, really big push right now to change the way that we talk to people about their diabetes. In a second here, I'm going to talk to you about a couple examples for you guys, but you saw it in the video. There are a couple recommendations. What it really comes down to is focusing on the person that has diabetes and speaking to them, number one, in a respectful way, but in a way that puts them in charge of their diabetes. Now, I understand, I am a realist. I have worked with this patient population. I'm an ER nurse. I know how people can be. I know that some people just don't care about their disease, and I understand that. So there is a difference between a patient that simply is showing you ways in which they just don't care about themselves. But when we go in and we make that judgment right away, we actually don't allow ourselves the opportunity to learn that maybe that is actually not their case, and maybe they have a very, very particular reason or circumstance that's preventing them from taking the best care of themselves as they could. But when we go in and we make assumptions and we don't really have a conversation, it makes it really difficult to achieve these goals. A couple words that we're really trying to get away from, and I'll tell you from personal experience, some of these words are trigger words for me personally, and the other words I'm like, well, they don't really bother me, but this is about the majority of patients with diabetes, and these are the recommendations. So compliant and not compliant, I personally have always hated this word. For a while they were saying we should use the word adherence. However, that really doesn't imply anything different. And when you label someone as non-adherent or non-compliant, it puts a huge label on that person, and it doesn't really explain the situation. What it does is I would say in a lot of cases, it shows a judgment. In some cases, you can have a truthfully non-compliant patient, a patient that has everything, every resource they possibly can have, but they may just be simply choosing not to take as well of care of themselves as they could. We want to use words that talk about their engagement, their participation. I have the little yellow star there because this is a really, I'm very passionate about the word diabetic. So we are not diabetics, we are humans and we have diabetes, right? We don't go around saying, look at that COPD, right? That's a person that has a disease, right? So I think this is a really big word. And again, I talked to some of my friends, that word they couldn't care less about them. So it's different for everyone, but I will say I think this is a really hot word within the community is diabetic. We are people that have diabetes. The word refused, it's a strong word. Again, it can be true in a lot of cases, but I would just say that person decided not to do what we asked them to do or what we recommended for them to do. Good control, bad control, they don't like those words. Those don't bother me personally so much, but I understand how they would bother someone. Good control, bad control, it puts a label. It's grading you, it's grading your blood sugars. Adults don't want to be graded. And then can't. Can't is a really important one, and for me, when I think of the word can't, I think about the diet stuff. Oh, you can't eat that. Well, that's not true. I remember when I was doing inpatient education, patients, they have a lot of sometimes fears or assumptions about when a diabetes educator walks in the room and they'll say, you're going to tell me that I can't eat this, and I would always have the same response to that, which is that you are an adult, and I'm certainly not going to tell you that you can't do something, and that's the truth, because we all are adults. Now, pediatrics have worked with a lot of kiddos that have diabetes, and there's some differences in that situation. However, with our population, when we're educating adults or taking care of adults, telling an adult that they can't do something is probably not the best word choice, especially when it comes down to eating. You can't have that, you can't have that. It's a decision we all make, right? And just briefly, blood sugars are so personal. When you know your patient's blood sugar, you don't want to use it as a one-time judgment. You don't want to make a negative comment about it. We're very private, some of us, about our blood sugars. It has only been within the past, I've had diabetes for 19 years, and only within the past year did I start even when people would ask me what my A1C is, being comfortable telling them that. In my wedding vows, my husband vowed to me in front of everyone to never tell anyone what my A1C was. So it's personal, it's so personal, and I just want you guys to know that. It's information you guys absolutely need in order to take the best care of our patients, but it is personal information, so please treat it that way. Okay, so just a couple quick questions. We don't have clickers, but just take a look at some of these numbers, and then the question is on the next screen. So these are some pretty outrageous numbers and pretty outrageous graphs, right? What do you think this person's A1C is? I feel like I'm hearing most people say C. Those are my blood sugars. And so that is just to show you guys that when we make judgments about one number, it's just one number, that's all it is. Now, those are graphs from, I've been collecting data for years, but just that to me is just my way of letting you guys know that these numbers, they are a one moment in time number. And variability is very important. I'm not going to talk about variability, but variability, how do you achieve that A1C? How low are your lows and how high are your highs? That's a really important piece as well. But again, okay, which person is appropriate for insulin pump use in the hospital? Patient that has a history of type 1 presents to the ER after attempted overdose of Humalog. 72-hour psychiatric hold is in place. 79-year-old female with a history of type 2 admitted for OBS after a trip and fall at home. A 21-year-old female in MICU with DKA. A 33-year-old nonverbal male that uses an insulin pump at home. His parents and caregivers manage it, but they are not present. Which of these patients would even fall within our criteria to allow them to be on an insulin pump in the hospital?
D.
Oops. B. There's no reason that this patient can't be on an insulin pump, right? So she trips and she fell and we're watching her, but the first one, they attempted to overdose with Humalog, so that's an obvious no. The third one, C, they're in the ICU for DKA, so we can't have patients in DKA on their pump. And a patient that doesn't manage his insulin pump on his own, if his parents were present, he would actually be a potential candidate for being appropriate for use in the hospital, but with no one present to manage it, that would not be appropriate. Nurses are not expected to manage or use insulin pumps at the bedside. Okay, last one. So you guys have to do some math. So this person that has diabetes is eating 30 grams of carbs, blood sugar is 240. The insulin to carb ratio is 1 to 15, so 1 unit covers 15 carbohydrates. The correction factor is 1 to 70, so 1 unit will lower the blood sugar 70 points, and we want to calculate it to where the blood sugar goal is 100. Let me give you guys a couple seconds. Four? Yes, it's 4 units. So insulin to carb ratio is 1 to 15. So 30 carbs, so they're going to get 2 units for a total of 30 carbs. The blood sugar is 240, so it's 140 points above their goal. So they're going to get an additional 2 units on top of that to get to a blood sugar of 100. All right, and that's all I have for you guys.
She had to accept she really does have diabetes, not just pretend anymore. And so I'm trying to keep in touch to make sure she's okay. And so today she sent me a text saying 98 an hour straight across, left to right. But there is a wee place, she's Scottish as well, there's a wee place showing a red line. Then it took off now and I've just had toast and it's coming down again. I don't think I can work this new fandangled gadget. That's what she thinks about her CGM. So, but I thought it would be easier than having to stick her fingers all the time, because it's not nice. So we'll see. So that's just her view of it. But I really want to thank Kelly. I think she did a fantastic job. We need to do and what we need to take care of, that we're not really thinking about the patient. And it's like when we're teaching a class, it's about what we want them to know, what they want to know. We don't always take into consideration. So I know that's very personal for you because I know you. But thank you for giving us a view of what it's like. I really appreciate it. Okay, well, we've come to the end of our day, and I'm looking at Marissa to see if she's got the raffle cards, because we always do this at the end of the day. I hope you all really enjoyed it. I hope you enjoyed the speakers and that you learned. I think they were some of the best speakers that we've had. It was really enjoyable. And I know that you're anxious to get home now, but let's get this on. Okay. So how do you want me to do this? Do you want me to do the first pick as the star prize? I think I should. So our prizes are that we have the 2-night stay at this hotel, and I'm going to draw one of the raffle tickets now for that prize, okay? I don't want to be accused of anything.
That's not to be accused, right? Okay.
Okay, Charmaine was